presentation because we are getting feedback into the system when we're recording. Thank you. So this morning, I'm delighted to introduce Anne Menardi, who joined our group, our faculty in October last year. Anne's going to be talking about pleural effusions, but I know for all of you in the room and those of you who are listening to her watching this presentation, she needs no introduction. Anne got her undergraduate degree in math and biology at Johns Hopkins and went to Jefferson for medical school in Philadelphia, and then has been a true Yalie for both residency and pulmonary and critical care fellowship, after which she joined our group. Anne is passionate about researching the healthcare disparities in medicine, particularly with regards to respiratory care, and she has devoted 25% of her time here to research, which is a refreshing aspect of Anne's employment here, that she spends so much time in research, and has combined her interests in pulmonary medicine with a few other skill sets. For one, she actually went to, was part of a 7-member delegation of the American Thoracic Society to Capitol Hill, where she met with our representatives, and including Senator Lamar Alexander from Tennessee, to advocate for the needs of patients with respiratory diseases in this country. And she, as you can see here, and she also combines a talent for pulmonary medicine with baking. And as you can see, she baked this cake in the shape of a lung, and is pretty intricately done, right down to the bronchoscope entering the right main stem bronchus and all the alveoli. So, Anne, thank you. I'm sure you would have done a cake on pleural effusion if you had the chance. So we're looking forward to your talk.
Thank you very much for that introduction. Thanks to the people who came and are here in person, which I was not expecting. It's very exciting. And thanks to everyone who's watching or listening at home. So I'm going to talk about mainly the diagnostic evaluation of pleural effusions. When I started making this talk, it turned out that pleural effusions is a huge topic with lots of evidence. Even though the first thoracentesis was done, I think, by Hippocrates, from what I can tell, we're still debating fine points of the procedure and evaluation today. So I'm going to present the various aspects of the evidence that we have and that we're still thinking about. Here's an outline. I'm going to talk about the physical and radiographic exam for pleural effusions, talk about ultrasound, some aspects of physiology of pleural fluid production and drainage, a little bit about the thoracentesis procedure and evidence for peri-procedural management and complications, and then touch on pleural fluid analysis. And I'm going to start by talking about a patient case who I saw in the hospital on the consult service a few months ago. This was a 38-year-old man who presented to the emergency department with 1 day of fevers, cough, and pleuritic chest pain. He also had lower extremity pain. He had a history of CLL. He had been on maintenance treatment with dasatinib for 3 years, and other history was significant for incarceration 8 years ago, otherwise pretty negative review. He was febrile and tachycardic in the emergency room. He appeared uncomfortable. His lower extremity exam showed a large patch of edema and erythema on his left lower extremity, and you can see from the labs that the overall picture looked concerning for an infection. And of course, given his presenting complaints, we were concerned about pneumonia and possibly a pleural effusion. And I was consulted to comment on management of the pleural effusion. And one thing that I was thinking when looking over this case was, and I didn't include the lung exam here, but I was thinking about how so much of when we're consulted for a pleural effusion, we already have imaging. Sometimes we even have a CAT scan, and we did in this patient. But I was thinking about how the physical exam is something that I learned in medical school and that we think is a good tool to detect pleural effusions, but that we just go straight to the imaging now. So I wanted to go back to the physical exam, and I will shamefully admit that I don't do a lot of these maneuvers, but now after looking into this a little more, that maybe I'm going to change my practice. But so this was a study which was actually a meta-analysis of about 1,000 patients with pleural effusions, looking at the diagnostic maneuvers to identify their presence. So the diagnostic maneuvers are listed here, and then this is a busy table. Oh, it didn't pop up. This was a table showing the sensitivity, specificity, and likelihood ratios of the different maneuvers, but I've summarized the findings at the bottom. So dullness to percussion on exam most increases the likelihood of the presence of a pleural effusion. And if you remember, dullness to percussion is when the examiner puts their finger horizontally in rib spaces and taps the DIP with a finger on the other hand and looks for a change in the percussion noises. And the absence of reduced tactile vocal fremitus most decreases the likelihood of a pleural effusion. And tactile vocal fremitus is when the examiner puts their hands on the thorax of the patient and has the patient say a low frequency word. And this has been mistranslated because the initial exam was in German, and the German word for 99 was the low frequency word that was used. We were taught to say 99, to have the patient say 99. That's actually not a low frequency term. You're supposed to have the patient say something like boy or toy, and then feel for whether that the voice is transmitted through their thorax, because it should be in a normal lung. However, this is blunted by the presence of a pleural effusion, and so the tactile vocal fremitus is reduced. So the absence of that finding decreases the likelihood of pleural effusion. So I would encourage everyone to try these physical exam maneuvers, lest we lose these skills in the presence of the omnipresence of imaging. Into the initial workup for pleural effusion, right? So looking at our imaging findings. So we know that most patients have a chest x-ray when they come in with a pulmonary complaint. And early on in the advent of ultrasound, it began to be used to evaluate for pleural effusions. And this study is from 1976, was published in Chest, and was the first study to directly look at chest x-ray versus ultrasound for the diagnosis of pleural effusions. Presumably these numbers have changed somewhat, but you can see that the sensitivity and specificity of pleural ultrasound is better than chest x-ray, which is not surprising because we've all had cases of false negatives or false positives on chest x-ray. Either there was not enough fluid to see on the chest x-ray and you end up finding it on ultrasound, or what looks like fluid on x-ray actually turns out to be consolidated lung, atelectasis, something else. So this was a meta-analysis that looked at many studies that took into account the sensitivity and specificity for chest x-ray to find a pleural effusion. And it turned out that it really depended on the amount of fluid that was present and the patient position. So for example, lateral decubitus chest x-rays are very accurate for finding pleural effusions. And this was proven in a study back in the 70s when the authors actually injected fluid into cadavers, into the pleural space of cadavers, and then took x-rays to see how little fluid they could detect. And they could find as little as 5 cc's injected into a pleural space using this imaging technique. An upright film is not quite as good, but better than a supine film. So you can see that upright film has sensitivities in the 80s. Here's an example of an upright lateral and upright PA chest x-ray. So the upright lateral can detect as little as 50 cc's, and the PA can detect as little as 200 cc's. Here, in both cases, there's a meniscus, which is not the first finding. The first finding of a small amount of fluid is blunting of the costophrenic angle, followed by the hemidiaphragm being obscured, and then seeing a meniscus like this. So this is actually probably more fluid than we would see if it was just the 200 cc's minimum. But unfortunately, the supine chest X-ray is not a very good test for detecting a pleural effusion with great accuracy, and that's because, as you can see here and you can imagine, the layering out of the effusion in the posterior hemithorax means that there's not one particular spot where the fluid is accumulating. So when the X-ray beam passes through, there's fluid all throughout the hemithorax. And so this is a study that examined the ability of a supine film to detect various findings, and it makes sense that the most common finding in a supine film with a pleural effusion was just increased opacity of the hemithorax because of the way that fluid layers out. And the findings that we commonly see on an upright X-ray, like loss of the diaphragm and that meniscus, were less seen even in larger effusions. So when we think about all those X-rays that we get in patients in the ICU, or even just hospitalized patients in general who are laying down, we have to consider, are they really sensitive for what we're looking for? And if it's a pleural effusion, then the answer is maybe not. And we know that ultrasound, including point-of-care ultrasound, has sensitivity and specificity in some studies going up to 100%. So, of course, we would encourage you to always use an ultrasound or call us to help you with an ultrasound if there is a suspicion for an effusion. And I'll just quickly go over some of the imaging from our patient case. So this was, leave me alone. Okay, so this was the patient's chest X-ray, and there's a few things that you can note here right off the bat. You can't see the sides of this patient, so this is a patient with a lot of thoracic adiposity, and there's clearly on the left side here, in addition to not being able to see the costophrenic angle, you can't really see the hemidiaphragm, and the left heart border is obscured. So there's suspicion for an effusion here on the left side. And here's a CT scan that he had also on presentation. In the middle, we have it with lung windows, and you can see the effusion here on the left side. Otherwise, the lung parenchyma looks pretty much clear, and then this is more superior and more inferior in abdominal windows. And the abdominal windows allow you to see the pleural fluid appearing darker gray, with the adjacent atelectatic lung here appearing somewhat lighter gray with air bronchograms. So I'll talk a bit about ultrasound and how it's used to look at the bedside for a pleural effusion. My main recommendation is to do this the same way every time, which I know can be difficult if different people who are us pulmonologists may have different ways to doing it, and as a learner you may be exposed to different techniques. But as much as you can, to try to do it the same way every time so that you know what images to expect on the ultrasound machine. I use the cardiac probe with the indicator pointed toward the patient's head, so it's a longitudinal exam, and I scan in multiple rib spaces and multiple lines. And like I said, doing it the same time every time means you know what to expect. And what you're looking for, what a pleural effusion looks like on ultrasound, is hypoechoic space. The boundaries are the chest wall, the lung, and the diaphragm. And you want to see dynamic changes from the patient's breathing or from the heartbeat to know that you're in the right place, because if you don't see these structures moving, maybe you're actually in the abdomen or somewhere else. So here's an example of an ultrasound image. We have, to orient you, the patient's head would be over here, and more caudal would be at this end. So we have a hypoechoic space, so that black space. The boundaries are here. The chest wall is nearest the ultrasound probe. The diaphragm is on the caudal side. The thorax is above that, and that lung that you can see is scrunched up, obviously, because of the presence of the fluid around it. And this doesn't show the dynamic changes, but we'll see if this video does. This is a video from the American Thoracic Society, and you can see here that we have the hypoechoic space, our borders, including the diaphragm, and everything is moving. You can see a fine movement with the cardiac cycle and then movement with the respiratory variation as well. And then when you do pleural ultrasound, you may find some unexpected findings. So we can see the septations in the pleural effusion, which would likely mean that this patient needs more than just a simple thoracentesis. You can see nodules on the pleura. There you can see them on the diaphragm. And then sometimes when you think you're going to see a pleural effusion, you actually end up seeing a consolidated lung, because the chest x-ray, as we know, if that gave you the initial suspicion, does not always detect with sensitivity an effusion. So here's an example where we have the diaphragm and the liver below it, and above it, instead of having that hypoechoic space and the lung, we just have consolidated lung throughout. So how did the fluid get there? I'm going to talk a bit about, probably more in depth than anyone's ever thought about, the production and drainage of pleural fluid. But if you can understand the physiology, you can better understand the pathophysiology of pleural effusions. So just a reminder, this is a schematic of the layers of the pleura. So depicted in red is the visceral pleura, which is adherent to the lung, and it fills in the fissures as well, and then reflects at the hilum and the mediastinum back to form the parietal pleura along that lines the inside of the chest wall. So I'm going to zoom in further here to this image of the visceral pleura. So the pleura is composed of a layer of mesothelial cells, which are specialized squamous cells, and below that a layer of connective tissue through which there are vessels and nerves. And that constitutes the pleura. In this picture, you can see beneath that is the lung parenchyma with the alveolus. Covering the mesothelial cells are microvilli, and these microvilli are covered in surfactant molecules. And surfactant is negatively charged. So if you have microvilli on the parietal pleura and microvilli on the visceral pleura, and they both have negatively charged surfactant, this causes the layers of pleura to repel each other, and this contributes to the negative intrapleural pressure. The production of pleural fluid comes from the filtration of blood that's passing through the blood vessels in the connective tissue of the pleura. So these are these vessels on the, just to orient to this diagram, so this is going from out to in, so this is chest wall, then we would have ribs and intercostal muscles, then the parietal pleura with its mesothelial layer here, the pleural space, then the visceral pleura and the lung on this side. So the vessels in the parietal pleura come off of the intercostal vessels, and those in the visceral pleura come off of the bronchial vessels. So they both are systemic circulation, and you can see that those in the parietal pleura are actually closer to the pleural space. And that's important because the pleural fluid is produced by filtration of fluid out of these vessels into the interstitium, and then by gradient, that fluid ends up in the pleural space. On the visceral side, because these vessels are farther away, when that fluid diffuses into the interstitium, it may end up getting collected by lymphatics before it makes it into the pleural space. So most of the fluid in the normal situation comes from the parietal side. And then the pleural fluid is drained by lymphatics in the parietal pleura. And that I'll show a little bit better in this diagram. So you can see here that there are lymphatics on the visceral side, but they don't connect to the pleural space. So no drainage of the pleural space takes place through the visceral pleura. These lymphatics drain the interstitium of the lung and take the drainage to the local intrapulmonary and hilar nodes. So this explains some of our staging for lung cancer. The difference is that the parietal pleura drains the pleural space directly, because you can see that there is a direct connection in between the mesothelial cells, and takes that drainage to mediastinal or diaphragm nodes. So we know that malignant pleural effusions, their presence means that the patient automatically has a higher stage cancer, and that is in part because this pleural fluid is being taken to extrathoracic and higher level lymph nodes than if it had just been draining the lung itself. As I said, the opening through which the pleural fluid comes is called, or you can see here, they're called stoma, general opening. In the stoma here, you can see this is in a monkey parietal pleura with an electron microscope, so you can see actually the openings in the pleura. And these authors injected carbon particles into the pleural space of a monkey and then watched them cross from the pleural space through the stoma into the lymphatic system. We know that we keep a very small amount of pleural fluid in the pleural space at all times, but it's a very small amount. 0.2 cc's per kg per day is the amount that's produced, which comes out in a normal-sized adult to about 15 cc's per day. And then the drainage approximately matches that so that pleural fluid does not accumulate. If the pleural fluid production increases, the lymphatic drainage has the capacity also to increase its drainage to maintain that balance. And it can increase its drainage up to about 20 times normal to maintain that balance. But if the production of fluid really increases, or if there's some obstruction to the lymphatics, then a pleural effusion is going to accumulate. So we can talk about first what causes increase in pleural effusions. So this is Starling's law, which dictates how fluid crosses from a vessel. So generally, get this picture over here. So the factors that we're looking at here are the difference in the vessel and the interstitium in pressure, meaning hydrostatic pressure, and the difference in the vessel and interstitium in oncotic pressure. And then this important K is the permeability of the capillary membrane itself. So changes in parts of this equation will lead to changes in the amount of fluid that is filtered. So one change that can happen is an increase in vascular permeability, and that could occur in the setting of infection, some inflammatory disease, or malignancy. Any of these things can violate the integrity of the wall and allow fluid and the contents of the fluid, including proteins and other molecules, to increasingly spill into the interstitium and the pleural space. So increased vascular permeability of any cause will usually lead to an exudate, because that is the entire contents of the vessel and not just the fluid itself are coming out. In contrast, if there's increased hydrostatic pressure, this will result in a transudate, because the filtration, the barrier is intact, but it's just the fluid that's being drawn out by the hydrostatic gradient. So heart failure is a common example of this physiology causing a pleural effusion. Decreased interstitial or pleural pressure can cause an effusion. We see this sometimes with atelectasis, resulting in more negative intrathoracic pressure, which tends to draw the fluid into the pleural space. And then a low oncotic state, such as in patients with renal failure or heart failure, will cause increased fluid production. Lymphatic obstruction at the gross level or the local level will cause decreased pleural fluid drainage. So the thoracic duct and the lymphatic duct drain into the SVC. So obstruction of the SVC, like in the case of SVC syndrome, can cause decreased fluid drainage, or the presence of a lymphoma or a carcinoma obstructing the lymphatics can also prevent the fluid drainage. At the local level, there are multiple disease states as listed below that can cause inflammation that prevents the free flow, free drainage of the fluid through the lymphatics. So there are many entities that will cause pleural effusions by multiple mechanisms. So for example, in the case of empyema, that's going to generate a lot of inflammation in the pleura that's going to compromise the integrity of the vascular wall and allow a lot of fluid to spill out and cause an effusion. And at the same time, the presence of the empyema is going to lead to the inflammation and pleural thickening that's going to impair the drainage of the fluid. So a lot of conditions have multiple mechanisms that allow the effusion to build up. And then, of course, there are causes of pleural fluid that don't have to do with the pleural space filtration and drainage, such as are shown here. Hepatic hydrothorax is when ascites from the abdomen passes through slits in the diaphragm into the thorax, and a common misconception is that this can only occur on the right side, when in fact about a quarter of them occur on the left, interestingly. VP shunt can lead directly to CSF accumulating in the pleural space, and then of course hemothorax from trauma is another possible cause. So once we recognize that there's fluid in the pleural space and we want to get a sample of it to better understand why it's there, or to therapeutically treat someone who's having symptoms like hypoxemia, or in our patient's case, he was having pleuritic chest pain, we want to do a thoracentesis to get some answers or to help the patient. And obviously procedures are best taught in person, but I'll go over some important aspects of the thoracentesis procedure. I think the most important thing is to position the patient correctly, because the patient is going to be in this position for a little while, and you want them to be comfortable and safe, and you want to be comfortable and safe. And so positioning, taking the time to position, is a really high yield use of time. The position can be the A, B, or C shown here. What's really important though is that if you do an ultrasound and then put the patient in another position, you need to re-ultrasound, because the fluid is going to shift around. And it's been studied that for example, sending a patient to have an official ultrasound and have the ultrasonographer mark the spot of the pleural fluid, and then doing a thoracentesis after some amount of time has passed, is not a great procedural technique in terms of safety because of the fluid shift. So you want to ultrasound the patient in the position you're going to do the thoracentesis in, and do it right before the procedure. The triangle of safety is shown here. This is bordered by the pec muscle, the lat muscle, the axilla, and the fifth intercostal space. And this defines the area where we think that the vein, artery, and nerve will be well tucked up under the rib. As we get more posterior, these vessels tend to potentially hang down under the rib into this intercostal space where we're going to be going with our needle. So that's why this is considered a safer area. And of course, we go over the rib rather than under, because we're trying to avoid these structures. Some people aim for the rib itself and then walk up just superior to it with the needle, which is not exactly what I was taught in my training, but of course that would be a way to guarantee that you're just where you are relative to the rib where you're hoping to be. The procedure should be terminated when a patient, either when fluid stops flowing, or if a patient has a lot of pain or a lot of coughing. Pain and coughing are expected part of a thoracentesis. The procedure itself is uncomfortable. The removal of the movement of the fluid in the pleural space can be uncomfortable and can cause a pleuritic pain, often a referred pain to the shoulder patient will experience during the procedure. So that's expected, but there is a level of pain which is not expected and which should cause the procedure to be terminated. And the coughing is also expected because that fluid had been compressing lung. That lung has a lot of mucus in it and stuff, dead cells and stuff. So once that lung starts to open up, that starts to move towards the more central airways, and the patient feels the urge to cough. And coughing is also a normal part. Sometimes if a patient's coughing a lot, I'll just pause the procedure and let them kind of get over a coughing fit before proceeding. Intractable coughing, though, would be an indication to stop the procedure. There are multiple complications, of course, of sticking a needle into somebody's chest, and here they are listed, and I just want to go over some of them because I learned a lot from doing this presentation, and I think I actually might change some parts of my practice based on what I discovered, particularly in this section. So pneumothorax is probably our most, or one of the most feared complications of doing a thoracentesis. And the pneumothorax rate depends on the study that's looked at, but here are some from very large studies done over the past decade or so, about 10,000 patients in a few of them. So you can see here the pneumothorax rates are pretty variable, ranging from 0.6 to 6%. In this top study, they looked at also what factors were most associated with the pneumothorax, and the most strongly associated was whether ultrasound was used or not. So when ultrasound was not used, the rate of pneumothorax was a lot higher, as you can see here. And so the question is, if we are using ultrasound, if our likelihood of pneumothorax is very low, do we really need to be doing chest x-rays on everybody after we do a thoracentesis? And my practice has always been to do so, but this Choosing Wisely campaign discussed this question and said actually no, after a lot of research review. It doesn't seem that it's necessary to do a chest x-ray on everybody. And the reasons are listed here. So one is that we know that using ultrasound, if done properly and if the procedure goes smoothly, then the risk of pneumothorax is quite low. Number two, patient symptoms or issues with the procedure can pretty well predict whether the patient has pneumothorax. So a study was done that asked physicians after a thoracentesis whether they thought the patient might have a pneumothorax. And in procedures that had been complicated, like required multiple passes, or if the patient was moving around a lot, or if the patient had a lot of symptoms afterwards, the physicians were more likely to say that the patient probably had a pneumothorax, and they were right. So clinical judgment can be used to determine whether the patient likely has a pneumothorax. If the procedure is straightforward and afterwards the patient feels great and is like, I'm breathing so well, and they don't have pain and they're not coughing, then it's very unlikely that they have a pneumothorax. Importantly, the studies even that showed pneumothorax, very few of them were significant or required chest tube or anything like that. So even if these patients do have small pneumothorax, most of the time they don't require any dedicated treatment anyway. And then lastly, the chest x-ray rarely shows new or useful findings. So it rarely shows a pneumothorax, and it rarely shows anything else that's going to change what you're doing. So this is a particularly difficult one for me because obviously it's very fun to see like a really big pleural effusion and then get the follow-up chest x-ray and it's gone, and then that read says like, you know, marked improvement in the effusion or something, and you feel good about what you've done, but the truth is you knew that because you watched all the fluid come out, so you don't really need a chest x-ray to see it. However, the Choosing Wisely campaign is in agreement with the British Thoracic Society pleural guidelines that there are some indications to get an x-ray after the thoracentesis. So if air is withdrawn during the procedure, well, that tells you that there probably is air in the intrapleural space that should be addressed with a chest x-ray. If the procedure is difficult or multiple attempts are required, or if the patient is symptomatic, these could all be reasons to get a chest x-ray. So I think I might start for patients who have really smooth pleural or thoracentesis procedures, not getting a chest x-ray, see how that goes. Another complication that we need to potentially look out for is re-expansion pulmonary edema. And there's some debate about the true existence of this entity, and where I trained at Yale, I think people would take it about this seriously. Some studies have even asked the question of, does this entity even really exist? Here are some patient series that looked at re-expansion pulmonary edema. The first one, and the one that really got people sort of talking about this in the modern age, was this publication from 1988. And it was a series of 47 cases worldwide that were reported in the 30 years between 1958 and 1987. And so that paper was just a long list of all these cases of reexpansion pulmonary edema and a list of whether the patient lived or died. So not, this was not like a randomized trial. It wasn't even really a study. It was just a case series. And the resulting report, though, was that the mortality of this entity was 20%. And that came from the fact that 20% of the patients that were reported died. I think probably people were more likely to report this if the patients died, so we didn't hear about, these are cases that are being reported all over the world. Probably people didn't report these uneventful, oh, I did a thoracentesis, and maybe there was a little haziness on the chest x-ray afterwards. That's not going to end up getting reported. And also, so I think that probably artificially raised the mortality rate reporting. And also, it's just not, how a mortality rate should be derived. This is just a series of patients rather than an actual study. So that's all to say that a lot of papers that I read said that reexpansion pulmonary edema has a potentially very high mortality rate. And it's referring back to that 20%, but that's not really an accurate number. The studies that have looked at the actual rates of reexpansion pulmonary edema have found it to be very rare. So this was a study of about 10,000 thoracentesis procedures and reported 10 out of 10,000 cases of reexpansion pulmonary edema for a rate of 0.01%. So that's a very low percent. They noted the bleeding rate is 0.18% in that same series. And the reason I point that out is because I've heard of a practice of only draining like 1 liter or 1.5 liters at a time. So doing that procedure one day, and then if the person's okay, taking out more fluid the next day. But the bleeding rate is significantly higher than the risk of reexpansion pulmonary edema, meaning that if you're doing multiple procedures, you're actually putting the patient at a much higher risk for complication than just doing one procedure and taking all the fluid out at that time. So I usually advocate for just taking out as much fluid as possible from the patient unless they have new symptoms or develop symptoms during the procedure. Lastly, this study of about 10,000 patients just came out last week and had a similarly quite low rate of reexpansion pulmonary edema of 0.08% and noted a few risk factors for reexpansion pulmonary edema, including higher ECOG score and removal of greater than 1.5 liters. So it has always been thought that removal of a greater amount of fluid it leads to higher risk of this syndrome. Some of the studies show that actually even with a very small amount of fluid removed, it's possible. So it almost seems like it can occur at random and maybe not even be related to the procedure. So if you can tell, I remain sort of skeptical about this as a major risk of a thoracentesis. But I think that in general, because the risk is so low, that we can feel comfortable removing a comfortable amount of fluid unless the patient has significant symptoms. The management of anticoagulants and platelets around a thoracentesis has been studied a lot recently. And I'll show you a few studies. This one was done by 2 interventional radiologists at the Mayo Clinic. So these people obviously were very adept at doing this procedure, but they would do it in patients no matter the INR, no matter the platelet count. As you can see on the left side, this was a large range of INR, large range of platelet counts. And they did it using the vacuum suction bottles for the most part. And they would usually drain the volume of that bottle, which is 1.2 liters, but sometimes they would drain more and sometimes less, depending on the clinical picture. And you can see that they had a 0% complication rate, no bleeding at all, and no bleeding no matter how high the INR was or how low the platelets were. So this may argue against, worrying about those factors when thinking about doing a thoracentesis. You may say, like, these people this is IR, they have their fancy gadgets and stuff, so what about just doing, what about us normal people doing it? So this is a study from Yale, from a lot of the people that I learned to do thoracentesis from. And they retrospectively evaluated the bleeding risk in patients who they had done thoracentesis on. So you can see the list here of the different bleeding risks, and they include thrombocytopenia, high INR, patient being on Plavix, patient being on therapeutic Lovenox or therapeutic heparin, or a patient with renal failure, and looked at whether having this bleeding risk or not having this bleeding risk led to increased bleeding. And in fact, there was no difference in the patients who had any of these risk factors for bleeding and patients who did not. You may say, okay, well, that's great, but maybe we'll just correct the INR or correct the platelets anyway just to be safe. So here's another study. It looked at 1,000 patients, or 1,000 thoracenteses, and this group 1, these patients did not receive any blood products, even if they had an INR greater than 1.6 or platelets less than 50,000. And in group 2, if they had those abnormalities, they received either FFP or platelets to correct them. And actually, all of the bleeding complications occurred in group 2, in this group where they had received the blood products. And I don't know if there's a direct causation there of the patients received those blood products that had more bleeding, but it just goes to show that there was not a benefit from improving the numbers in terms of INR or in terms of platelets. So I think we can become more confident in doing these procedures without giving blood products first, knowing that they don't help and that every transfusion carries with it a small but real risk. I'm going to talk very briefly about the different modes of drainage and the evidence for them. So gravity drainage is basically putting in the catheter, not applying any suction, and just letting the pleural fluid flow out. I've actually never seen that used, but there was a study published on it just this year, so I guess that this is a practice some places. Manual suction means that using a two-way valve, the fluid is continually drawn out by syringe and then pushed into a bag. This is a bag that most people just throw away when they open the kit. Throughout my I spent like most of my fellowship like pulling on this suction syringe. The vacuum suction seems to be more what we use here to my relief, and that involves using these glass bottles the same as we use for paracentesis. So this study compared using the drainage method to using suction, and it was published just this year in Chest in 2020. The outcome was whether there was increased pain related to the procedure, and the outcome was that there was not a difference between patients who just had passive drainage and patients who actually had suction. Comparing the manual suction to vacuum suction, this was a study also done at Yale that looked at 100 patients who either had the manual suction or the vacuum suction, and there were more complications in the vacuum group. So this is part of the reason I think that they made us fellows use the syringe instead of the vacuum bottles. You can see that there were 3 pneumothoraces, 1 hemothorax, and 1 re-expansion pulmonary edema in the vacuum suction group, whereas there were 0 complications and less pain in the manual group. But criticisms of this have said this is just 100 people, and these complication rates are so rare, as we saw from other studies, often less than 1% bleeding, risk of bleeding or pneumothorax. So is this really a sample size that's adequately powered to say that one is more dangerous than the other? Here's a study with a very large sample size, over 10,000 thoracenteses, and it looked at the drainage by suction as well and reported low rates of pneumothorax and re-expansion pulmonary edema. But this just came out last week, and I don't know any other details of the study because it's so new I wasn't able to access it online. So I don't know if there was a particular suction method that was used or if it's going to add anything to that literature. Suction was used, but I don't know if it was vacuum versus manual versus both, and if we get some additional data from that. Okay, so the last thing I'm going to talk about is the pleural fluid analysis. So once we do a thoracentesis safely and get our samples, obviously our goal firstly, is to determine whether we're dealing with a transudate or an exudate. And a lot of times we know this based on the patient's history and based on their other physical exam findings, et cetera. So we can make it more official, though, using the Lights criteria. So Richard Light is a professor of medicine at Vanderbilt, and when he was a resident at Johns Hopkins, he invented the Lights criteria. And they are listed here. The protein ratio between the pleural fluid and the serum being greater than 5, the LDH ratio between pleural fluid and serum being greater than 0.6, or LDH being greater than 2/3 of the upper limit of the serum LDH. And these criteria have really stood the test of time. So here's a study, just an example. A lot of studies have looked at using other things besides the Light criteria to determine transudate versus exudate. Here's an example of a series of 31% were transudates, 69% were exudates, and this study looked at the Lights criteria, albumin, cholesterol at different cutoffs, pleural to serum cholesterol ratio, bilirubin ratio to determine transudate versus exudate. So testing whether all these different molecules can help to differentiate. I also saw studies that looked at alk-phos, presepsin, CRP, procalcitonin, creatine kinase, uric acid, oxidative stress levels, and others to look for the perfect thing to differentiate between transudate and exudate. But it turns out that the Light criteria is still the highest performing with a sensitivity of 98%. However, these criteria don't have great specificity. So this means that the Light criteria misclassify maybe a quarter of the transudates. They say the criteria will be met, will say that they are an exudate when actually they're a transudate. And this most commonly occurs in patients who are getting diuresed, like patients with heart failure or patients with liver failure. So in this study, patients were getting diuresed throughout. The mean weight loss was about 3 kilograms. So during the course of their diuresis, over the course of about a week, they had 3 thoracentesis, just little diagnostic thoracentesis to look at the makeup of the pleural fluid. And you can see that going from the initial one in the first column to the second to the third, the protein, the LDH, the albumin, all these things increased significantly. So the thinking is that if you do the thoracentesis immediately, the patient, you can diagnose the transudate. Once the patient's been diuresed, the composition of the fluid changes because the pure fluid part is being drawn out, so the concentration of these other things increases in the pleural fluid, and it starts to look like an exudate. So that's why about a quarter of these look like exudates when they should actually be transudates. So what do we do about these, and how do we know to reclassify them as actually transudates? There have been multiple studies looking at how to reclassify, and this is a study from 2014 that found that looking at the albumin between the serum and the fluid may be the best way to differentiate. So I think it means that we should consider sending albumin. I don't usually send albumin unless I have a really high suspicion for a transudate, so it's probably a good thing to send in case you end up needing to look at this question. So if you get an exudate by Lights criteria, but by pretest probability, you really think this should have been a transudate, you can either look at the protein pleural to serum ratio, which is part of Light criteria, so you already have the protein, or look at the gradient, so not the ratio, but the gradient of albumin between the serum and the pleural protein. And if that's greater than 1.2, or if the ratio is less than 0.6, then this may reclassify your exudate as a transudate as it should be. So something to keep in mind if you get an exudate that's sort of unexpected, that you should reevaluate it with this other criteria. Other once we have the transudate versus exudate, there are other factors that may be helpful in figuring out the etiology of the effusion. This is a table in the British Thoracic Guidelines for Pleural Disease that I don't think is really helpful at all, because food particles, bile, I mean, those are sort of obvious and not really like not really the mysterious cases that we're talking about. I just included this because it talks about this anchovy sauce fluid, and my husband is Sicilian and we eat a lot of anchovy sauce, and I never really thought about it as being related to a ruptured amoebic abscess before. These are the various studies that could be sent from pleural fluid. So firstly, the cell count and diff. This really helps us to understand the cause, particularly of an exudate. So here are different causes of lymphocytic pleural effusions where lymphocytes are greater than 50%. It has, I mean, this is a decently long list, but it has a pretty narrow differential. So if you see lymphocytes, then you know that you're looking for a particular potential group of diagnoses compared to a neutrophilic predominant, which we would expect in infection or empyema. Then the other at the top, proteins, LDH, we talked about. Glucose is usually low in infection and other certain exudates. The pH is useful in looking at an exudate and deciding whether, if this is a parapneumonic effusion, whether it probably needs to be drained. Otherwise, the pH doesn't necessarily have a major role. The normal pH for pleural fluid is 7.6, so anything in the range from 7.2 to 7.6 may not really add too much to your diagnostic evaluation. We talked about how albumin may help reclassify exudates as transudates. Triglycerides would be elevated in chylothorax. Chylothorax is when lymph accumulates in the pleural space, and this may be due to certain conditions cause production of lymph, but often it's due to obstruction, such as due to malignancy, that leads lymph to accumulate in the pleural space, and then the drainage would be sort of a milky-like looking substance. Cholesterol can be measured. It can indicate an exudate, as we talked about. It can be part of the criteria, or it's been evaluated, its utility has been evaluated in differentiating transudates from exudates, but it's not super sensitive. And then there's also something called a cholesterol effusion, which is when an effusion has been present for a long time. It can end up accumulating cholesterol. Excuse me. Amylase, as expected, is elevated in GI causes of pleural effusion, such as pancreatitis or GI malignancy. Adenosine deaminase, ADA, is elevated in tuberculous effusions. And then creatinine is elevated in a urinothorax, which is usually due to an ipsilateral ureter obstruction. BNP and procalcitonin don't seem to have much diagnostic utility. There's been a lot of studied about looking at the pleural fluid BNP and whether it can help increase the diagnostic likelihood of identifying a pleural effusion due to heart failure, but it turns out that it doesn't add too much to the diagnostic criteria. Lastly, cytology should be sent if you suspect a malignancy, but we know that the sensitivity of cytology to detect a malignant pleural effusion is actually pretty low. So this was a study from 2014 that found only 51% sensitivity of cytology to identify a malignant pleural effusion. This study looked at multiple thoracenteses in patients with a malignant effusion and identified which thoracentesis actually found the malignancy. And for 65%, it was the first thoracentesis, but for 27%, it was actually found on the second. So that indicates that if it's not found on the first, then doing a second thoracentesis might help increase the sensitivity, and you might find the malignancy. But after that, the sensitivity really drops off. So the recommendation is to do, if you're looking for a malignant effusion or suspect a malignant effusion, to do 2 thoracentesis, and after that you don't really get much added value, so then to do a different type of procedure such as a pleural biopsy to determine whether that's the cause of the pleural effusion. Okay, so I'm just going to turn to the case. So if you recall, our patient who came in the beginning, he had fevers and cough and physical exam findings concerning for pneumonia, and his CT had that moderate-sized effusion on the left side. So here's the differential that we were working with. He could have had an infection, malignancy, some other inflammation we weren't thinking about, a drug reaction. And here's his pleural fluid analysis we did, well, Dr. Shapiro did. I supervised a thoracentesis removing 1.8 liters of serous fluid, and I'll just highlight some features here. There were 91% lymphocytes, and this was an exudate. After getting the high lymphocyte count, I sent off the adenosine deaminase because high lymphocytes in an exudate can be concerning for tuberculosis, but that was low. So this, in summary, was a lymphocyte-predominant exudate, and ultimately we made the diagnosis of a pleural effusion due to dasatinib. So dasatinib causes lymphocyte-predominant exudates in about 20% of the patients who are on it, and patients who are on dasatinib for CLL are often on it for years and years. So they, throughout that time, have this risk of developing effusion at any time. And with oncology, they decided to switch his dasatinib to nilotinib, and this was his chest x-ray from a few weeks ago showing no recurrence of effusion. Really quick, just, hot topic, COVID-19. There have been many series, obviously, looking at the imaging in COVID-19, and effusions don't seem to be a big part of this disease. So some of these studies have reported as low as 0% in 81 patients, up to 14%. And obviously we have larger series that will help to understand this a bit better, but we don't think that it's a major feature of the COVID-19. So thanks for your attention, and sorry for the technical difficulties. In summary, we talked about the limitations of using chest x-ray to identify a pleural effusion, that the pathophysiology and thinking about the physiology of pleural fluid production and drainage can help understand the cause. Chest x-ray may not be needed after thoracentesis, something to consider. Thoracentesis is likely safe in patients with increased bleeding risk, so patients with a high INR from liver disease or Coumadin, patients with low platelets, we can probably safely proceed with thoracentesis in these patients. Leitz criteria is still the most accurate criteria to determine the difference between transudate and exudate, although there are a lot of other features of pleural fluid that are being explored and that can contribute to this workup. And the lack of specificity of the Leitz criteria means that you may need to do further testing. And medication should be considered as a cause of pleural effusion, particularly dasatinib in this patient, and there are lots of case reports online of other medications, cancer medications, heart medications, many others that can cause pleural effusions. A lot are just a few case reports, but it's always something to keep in mind. So thank you for your attention. These are photos from protests in Chattanooga on Monday night that my husband and I went to, and I just wanted to take the opportunity while I have this microphone to say that I personally think our responsibility as physicians is to recognize injustice and to speak out against it and to show our community who we serve every day that we are behind them. So thank you for your attention. Here are some other select references, and I'll take any questions. Yes.
Thank you for your presentation. I have one question about evaluating the products after thoracentesis. Do you recommend or maybe that ultrasound to check for lung sliding?
Oh, good question. The question was about using ultrasound to check for lung sliding. after a pleural or after a thoracentesis to rule out pneumothorax. And I'm glad you mentioned that. And there is data, and it actually is part of the Choosing Wisely campaign, the recommendation that you have the ultrasound at the bedside to do the procedure. You just switch over to the vascular probe and do a simple exam to look for lung sliding. And this was recommended as a way to improve your clinical suspicion for whether the person might have a pneumothorax. I should have included that. Thank you. Yes.
Do patients hold their aspirin or Plavix on the day of the procedure, or
The question was about holding aspirin or Plavix on the day of procedure. I don't usually, and based on the data shown here, a lot of these procedures were done in the part where I talked about the anticoagulation or antiplatelet, were done with patients on Plavix. I don't think there are formal recommendations about holding it now, and more evidence has shown that it's probably safe to do it with patients on aspirin and on other antiplatelets. So that would be my recommendation, is not to have people hold them.
And could you address eosinophilic infections or where there's high predominance of eosinophils? Because normally not, it doesn't help you diagnose the cause.
Mm-hmm.
But what do you do when you see 20%, 25% reaction?
So the question was about eosinic effusions. I mentioned that in the cell count, if you have neutrophils, you would think about infection. Lymphocytes has a certain differential as well. And then eosinophils sometimes come up in the cell count as well. And eosinophils, the differential includes malignancy, includes parasitic infection or other things that can cause elevated eosinophils. And can sometimes be elevated in something like pancreatitis as well. It's difficult to know what to do with the eosinophils and whether it necessarily helps you with the diagnosis. I would say that because it's so frequently elevated in malignant effusions, that it would increase my suspicion for a malignant effusion. But other than that, I don't have specific data about how to look into that. Great, thanks.